Hi, my name is Jennifer Moranke from Penn State Hershey Medical Center, and I'm pleased to be here today with Petros Benias from North Shore LIJ. We're here to talk about his study entitled Safety and Feasibility of Performing Peroral Endoscopic Myotomy as an Outpatient Procedure with Same-Day Discharge. So thanks so much for being here today.
No, thank you.
So what caused you to think about this aspect of performing POEM?
Yeah, so I think those of us that are in the space and performing POEM have noticed that the outcomes are such that patients don't even have pain after the procedure a lot of times. And you wonder why we're keeping them. And I think we've sort of adopted a certain surgical dogma for these procedures because they are obviously very complex and they have theoretical risk, such as performing them in the OR or keeping them overnight and performing routine esophagograms. And we know even routine esophagograms probably not necessary. And so we sort of started to do away with all of that. And as we changed our practice and learned what we could do and what we could get away with, we started to develop an algorithm. And as we got over the learning curve, we really adopted this algorithm going forward, which is really same-day discharge. And really for us, the crux of same-day discharge is about pain. Not that it's not safe to go home without pain, but I think we feel more comfortable if they don't have pain.
Gotcha. So how did you go about carrying out your study?
Yeah, so like I said, it was really two of us that had done consecutive POEMs going forward, like 103 patients. And what we did was we didn't give any pain medications during the procedure, right? So they all got Tylenol afterwards, and we watched them for 2 hours. And if they had pain, then they would get admitted. Other reasons for getting admitted were if you had technical complexities during the procedure that were characterized as an adverse event. We all know that mucosotomies can happen, they can range in severity. So if we had those, we would admit the patients. And if there were other situations, for example, like medical comorbidities, like one patient had hypertensive urgency, et cetera, those are all good reasons to keep people and watch them, and then take it from there.
So were there any variations that you saw between proceduralists in terms of who was admitted and who was not?
So I think that if you look at the bulk experience, really, there's a few things that really stand out as to what is at the root of why people get pain. Some of that is patient-specific, right? For example, duration of disease. So if patients had long duration of disease, we know that they develop a bit of an insensate esophagus. So some of these patients don't feel pain. They also don't feel when their esophagus is filled with food, and et cetera, et cetera. But some of them are really technically specific to what we're doing. And that has to do with the length of the myotomy, specifically in this study, and it has to do with also the duration of the procedure. And we had a very standardized myotomy length based on what we believe is accepted protocol for myotomies, but certain type 3s, et cetera, or other types of conditions where we went a little bit higher, we noticed that a longer length was associated with pain.
And so in your study, did the patients that were sent home, what was the incidence of adverse events?
Yeah, so it almost no real adverse events. There were really what happened with those patients is we had a very set protocol, and I think it's very important to stress that you really just can't send patients home and say goodbye, right? So keeping patients overnight, is really some kind of false hope that everything's just going to go well for the next 7 days, right? And getting an esophagram doesn't mean that they're just going to do great. What they really need to do is follow very strict guidelines, right? So we call them at 24 and 48 hours. We follow them up within 2 weeks. We see them frequently. We have very close follow-up in the first few months. They have really direct access to our staff, right? So the other thing is very important is diet. I think it's super important that they stay on liquid diet, clears, progress to full liquids over a week. We give antibiotics. We haven't done away with this kind of prolonged empiric course of antibiotics. And I think that's really close observation. And out of all the patients we sent home, because we sent home 62% of 103 POEMs. Okay, so that's a very high number, and I actually believe it can be even higher. So of all these patients, two basically came back for x-rays because they had this persistent chest pain, and it turned out really to be nothing. And I can actually tell you anecdotally, one patient actually came back, and very classic x-ray at just under 48 hours shows a little bit of capno-mediastinum. So everyone in the emergency room freaks out. No one knows what to do with this. And it's and I told him that it's totally normal. And he goes through this algorithm, and then 5 hours later he's discharged home. And this is a very classic scenario that we're overdoing the aftercare here in the wrong direction. What we should be focused on is diet and close follow-up. But these X-ray images, keeping them for prolonged periods in the hospital, this is false hope. This is not really going to ensure that these patients are not going to, have any delayed complications.
Right. So can you just go over the algorithm that you're now following based on these results?
So right now, what we do is after we perform the poem, all of our patients get intravenous Tylenol, which has actually changed our practice tremendously. It's very good. And if they have pain requiring narcotics within these 2 hours that we're watching them post-procedure, then we decide to admit them, right? And of course, if they have technical complexities that we think need observation. In the hospital, we observe them, and really we're monitoring for fever. This is the biggest factor. They should not really have fever. They can have low-grade kind of temperatures, 99s. They can have high white counts. They should all resolve. So really, this is what we're monitoring for. And when they go home, our staff is calling them continuously, make sure they're okay, and they have a very good post-procedure kind of like template for what they should follow.
Great.
Yeah.
So where do you see future work on this going in terms of making a minimally invasive procedure less invasive?
Yeah. So this is a philosophical argument, right? We've gone from open surgery to laparoscopic, and that paradigm shift really produced better outcomes, less infection, shorter hospital stays, and same-day discharge for a lot of surgical patients. Why shouldn't going from laparoscopic to endoscopic surgery do absolutely the same? And I think a lot of people know this, but this manuscript at least is the template for now maybe following a certain algorithm. How do you increase the same-day discharge rate, right? So if you think about what factors are really associated with pain, the length of the myotomy, as you come up higher into the inferior mediastinum, and the length of the procedure, why should any of those really be associated with pain? It really has to do with CO2 escape. And I think if we can find ways to minimize CO2 escape, we're going to find ways to actually reduce the percent of patients with pain, maybe even get this up to 80% or higher same-day discharge.
Great. Yeah. Well, congratulations on very nice data and study, and good luck with the same-day discharge.
Thank you.
Thanks so much for being here.
Yeah.